Hello, everyone, and welcome again to the Institute for Global Health Sciences COVID-19 series. Today, we have a topic that is of extreme importance. We will be talking to experts about the situation of COVID-19 in India. Why is it that India is happening such a surge? What is happening to neighborhood countries? So we have a panel today of experts, starting with Dr. Monica Gandhi. Dr. Monica Gandhi is a professor of medicine, and she's also the associate chief of the Division of HIV, Infectious Diseases and Global Medicine at the San Francisco General Hospital. And I must add that Dr. Gandhi has been a marvelous advocate for action, not contemplating things from afar, but willing to mobilize UCSF faculty and legislature in the state and in the country to make sure that the US is more aggressively cooperating with India in its current pandemic. So my admiration for Professor Gandhi for everything she has been doing, and she's also an exceptional presenter. We're also very happy and very honored to have two people that are on the ground in India and that can tell us exactly what is happening in the country with an inside information aspect. Dr. Yogesh Jaime is a affiliated faculty member of our Institute for Global Health Sciences, and we're very, very lucky to have him. And we have Dr. Inayat Singh Kakar, who's a public health researcher and a consultant in public health. So this exceptional panel will be talking about the epidemiology, we'll be talking about vaccines and vaccination in India, and then we will open for questions from the audience so that we can try and understand what happened, why, and what is the, looking forward, the possibilities of containing this epidemic in the subcontinent. So without further ado, let me pass it over to Dr. Monica Gandhi.
Well, thank you very much for having me to talk about, really this dire situation, I think, in South Asia and ways I think that we can all help and advocate. To speak about the COVID-19 surge in India, I'm really referring to also Nepal, Bangladesh, Pakistan, surrounding areas that are also having the effects of this. I actually want to talk a little bit about what I think happened in India, where is the situation where we are right now? What will it take to turn this around? And I do need to mention the B1617 variant and why we think vaccines will work against it. And so I think that is not something that we need to be worrying about. This is the so-called India variant or double mutant variant. So in terms of what happened in India, really, as you can see, the curve of what was going on in India was, over August and September, there was more of a surge. And then profoundly, starting around March 5th, there was what some people call the wall, an incredible increase in new infections in a country of 1.37 billion. It is important to remember that only 10% of people living in India have received a first dose of vaccine in this very large country. And what happened right now, as of yesterday, 263,000 cases just for days ago, the count was 400,000 cases, increase obviously, unfortunately, in hospitalizations and deaths concomitant with these number of cases. What happened in India that could have led to this incredible surge and tragedy? You know, I think what happened was essentially an idea that India had more immunity than it did. Idea that I had, which I take full mea culpa for. Many thought that there was likely more immunity in India than there was. There were seroprevalence studies performed in the urban slums in Mumbai in July over the summer. And they showed seroprevalence rates of 55 to 61% in very crowded areas in Mumbai. That is likely not reflective of the entire community. In fact, there are many middle class and upper class populations in India that were able to shelter. In fact, they were sheltering because so many there was an ability for people, their workers, to help them get food and help them do everything they needed to do to shelter at home. And so it was those who were at risk, as always in an infectious disease pandemic, are those who are poor. And I think that there was an assumption, because February was, the cases were so low in India, hardly anyone in the hospital in a city like New Delhi. There was thought to be more immunity, and the country massively opened up. This picture on the right-hand side shows you a picture of Kumbh Mela, the Hindu festival that was actually a little bit earlier, held ahead of time, even though festivals were canceled last year. And this sort of incredible density of population and people being around each other. Actually, that same study in the Lancet and Global Health that showed the high seroprevalence rate in slum dwelling populations did show that there was much less exposure in the general population, about 11 to 12%. And with all of this gathering, with all of these loosening of public health restrictions, the cases went up like a wall, not a wave, but a wall. At this point, what's the situation? Up till very recently, it looks like things have taken a downturn in terms of number of cases. There's big debate whether that's testing versus truth, but we were up to 350,000 to 400,000 cases a day, 4,000 deaths a day, which is likely undercounted. Hospitals have been overflooded. Many have died outside the hospital. Last week, COVID-19 has become India's #1 killer. There are 1 million people projected to die in India by August. And there are 100, to put it in context, there are 150 people dying every hour. This is a terrible picture of the crematoriums in India burning all night to cremate those who have died. Oxygen is in short supply. And as at the start of May, New Delhi's daily oxygen demand surged to 976 metric tons, which is actually more than twice its current supply. Only 33 oxygen factories in India are actually actively functioning out of the 150 that would be needed to supply the current oxygen demands for the population. Certainly what got relaxed was our 3 mitigation procedures that are so important until we get to mass immunity, which are masks, ventilation, and distancing. A place where there's so much overcrowding, distancing was hard. Masking had been reduced in the context of February when cases were so low, without population immunity, but with more of a complacency. And certainly ventilation is there, but not in crowded spaces. And masks, of course, truly in indoor spaces are not actually adequate at a surgical mask or cloth mask. This is work that the CDC and our group and others did about indoor spaces requiring really stronger fit and filtered masks, either a surgical with a cloth mask or a mask that you loop over your ears called fit and tuck in on the sides, because you need a stronger fit and filtered mask to reduce exposure to the virus in indoor non-ventilated environments. I want to talk about the vaccines in India so that I can talk about the B.1.617 variant. Of course, the 3 top ones here are the ones that are approved or authorized in the United States: Moderna, Pfizer, and Johnson & Johnson. But those aren't actually the vaccines that are currently available in India. The vaccines that are available in India are AstraZeneca, which is the fourth one here, which we have plenty of data on. This is the product made by University of Oxford, and it's called Covishield in India. And then the bottom one, which is made by Bharat Pharmaceuticals in India. And this is a different type of mechanism of action of these other vaccines. And this one is called Covaxin. When I tell you the mechanism of action, what do I mean by that? Well, actually, most of the vaccine candidates, except for Covaxin and two products made in China called Sinopharm and Sinovac, most of our vaccine candidates involve the spike protein of the virus. That is the piece of the virus that sticks out and connects to the host cell membrane. It's actually the spike protein and the receptor binding domain that these vaccines code for. All the mRNA vaccines code for this, the two mRNA vaccines, so does Johnson & Johnson, and so does AstraZeneca. The Bharat Covaxin product is actually a whole inactivated virion that's put into the host. So that is a different mechanism of action. And Sinopharm, Sinovac are also inactivated whole virions. Otherwise, all of the other vaccines that I had on that slide, AstraZeneca, Sputnik, Johnson & Johnson are adenovirus DNA vaccines. And then the two mRNA vaccines are Moderna and Pfizer. And they all do the same thing. They essentially code for the spike protein, and then your body raises an immune response to that spike protein. The reason I need to tell you about immunity for just a minute is to explain to you why I don't think that B1617, the India variant, is breaking through the vaccines. It's just that people who have gotten one dose of AstraZeneca, for example, like healthcare workers, are being exposed to quite a bit of viral inoculum and are having mild symptoms usually after the first dose. We're not completely protected until the second dose. But I have to remind you of immunity to explain why I'm not worried about variants. I'm more worried about cases. So if we think about immunity, remember B cells are ones that produce antibodies, that's in your body. And then remember the other major arm of the immune system that is actually the main arm of the immune system that fights viral infections, and that are T cells. So T cells are divided into CD4 and CD8 cells are actually our main host defense against viral infections. And importantly, all of these vaccine trials, including AstraZeneca, including the Covaxin, measured T cell immunity and showed us that we had strong T cell responses that are generated against the virus in the presence of these vaccines. What do T cell responses do for us? Even if a virus can slip through your nose, what T cells will do for us is modulate severity of infection. They will prevent you from getting severe disease with COVID-19. So having an adequate T cell response is actually incredibly important. And the reason that I say that is, let's look at the T cell responses that are generated by the two vaccines that are in India. If you look at just the fourth and fifth row here, the AstraZeneca and the Covaxin, you can see that the AstraZeneca is a 2-dose vaccine, so is the Covaxin. And they both measured both neutralizing antibody responses, and they took the time and the work to measure strong T cell responses that you generate against the coronavirus virus with the administration of these vaccines. AstraZeneca actually gives you strong CD8 cell responses and CD4 cell responses. And the Lancet publication on the Covaxin product showed strong Th1/CD4 responses that were developed in the phase 1 and 2 trials. If the AstraZeneca, we have in the clinical trials, 28,000 people studied across the UK, South Africa, US, Peru, and Chile, and there is 100% efficacy in the clinical trials against severe disease. All of the people in the clinical trials who were hospitalized or died from COVID were in the placebo arm, and none of them were in the vaccine arm. There was some variability across variants with mild disease in the AstraZeneca trial. And in the Bharat Covaxin product, we don't have a peer-reviewed publication of the phase 3 clinical trial. We only have a press release. And at least in the press release, Covaxin says it's 100% effective against severe disease, speaking to that strong T cell immunity, but it is 78% protective against more mild forms of the disease. as said in their press release. This is the results of the AstraZeneca trial that I just told you. Again, all of the severe disease in the major clinical trials of the AstraZeneca product or Covishield showed complete protection against severe disease, but more variability against the variants against mild disease. And this is the Lancet paper of the Covaxin trial, again, just showing the strong T cell responses. And here is the press release of the Covaxin trials that was published just by the company on April 21st, telling us that it was 100% protective against severe disease and about 78% protective against mild disease. So will vaccines work against the variants? They will, with your T cell responses. And that's important because it is important to get vaccines to India. It is important to protect against severe disease because that's exactly what's happening right now in the cases of severe cases in hospital. Are these cases, for a certain percentage of the cases, no matter who you are, young or old, they are being hospitalized and going into severe disease. And in the setting of low oxygen supply, dying from the simple lack of something as simple as oxygen. This is technical, so I won't go into this, but this really shows us how complex the T cell response is across the spike protein. And that if you put, for example, the complexity of the immune response against the spike protein with T cells is that there's 52 different CD8 cells, for example, that are formed across the spike protein. So even if you have a couple of mutations in the spike protein, even 13, which is what B1617 has, it's called a double mutant for unclear reasons because for a different reason, but it actually has 13 mutations across the spike protein. But your T cell response is so complex across the spike protein that there's 52 different places across the spike protein that T cells act against. So that even in the face of the B1617, there will still be a strong T cell response with Covaxin and AstraZeneca across the B1617 variant. And this is data from the Qatar mass vaccination campaign from last month from the New England Journal that isn't with the B1617, but this is showing the power of the mRNA vaccines across other variants. This was specifically by the time the Qatar got to the March time of their vaccination campaign, B1351 and B117 were both variants that were predominating in the country, and there was still 97.4% effectiveness against these variants with the mRNA vaccines. And also Covaxin has published just in a preprint, actually in a press release, that it is effective, and so is AstraZeneca across the B161 variant in India. And also there's some data that shows us that the mRNA vaccines are also extremely effective, not just with T cells, but with antibodies in this case against the B1617. So it really isn't a matter of not getting vaccines there. It's a matter of getting vaccines there. And that's what I really wanted to end with, is that if we infused more vaccines to South Asia now, we could see cases coming down almost immediately. If 10% of the population has only received their first dose, places like Israel, places like Michigan in the US, places like the US in general, showed that at a 40% vaccination rate first dose, that's when cases start plummeting. If we got 30% more of the population in South Asia, just one dose, cases would start coming down on their own because vaccines block transmission. We have multiple data. And so what are the two ways to get vaccines to India? This is an article that I wrote in Time magazine, but I think it's important to remember the history because all of us have been advocates on this call for HIV. If we look at the history of HIV waiving of patents, because in 1995 is when the World Health Organization put into place the TRIPS provision that said, actually, if you have a medical emergency in the world, you can temporarily waive a patent for a drug, for a vaccine, if there's something so important going on as a life-threatening disease and you have the solution. As you know, 1996 was the year that we had highly active antiretroviral therapy, but that access to those highly active HIV therapies was really only in US and Europe. In fact, in 2001, the same company that's making one of the current mRNA vaccines, Pfizer, made $47 billion in 2001, and part of their profit came from the selling of a drug called fluconazole, which is a simple antifungal drug that could be made for pennies. That was the only medication that we could use to treat cryptococcal meningitis, which is a severe opportunistic infection in AIDS patients. And we couldn't get access in sub-Saharan Africa and India and other places that had AIDS to even something as simple as fluconazole. In 2001, thinking about India, they made antiretroviral therapy for the world. They decided, and this was a Cipla Pharmaceuticals company and others, they decided to make a triple drug combination for the world at $350 a year, which was less than $1 a day. South Africa wanted to purchase that because the sub-Saharan Africa epidemic of AIDS was not going the way that the US and Europe was with these highly active antiretroviral therapies. And when South Africa purchased drugs from India, antiretroviral therapy, there was a large lawsuit levied against the South African government by big pharmaceutical companies. With so much international pressure, like from people on this call, from advocates, from the international community, that lawsuit was dropped. And as you know, and its history, 2004 was PEPFAR, and then Dr. Eric Gooseby later became the PEPFAR director. And it really was India that provided antiretroviral therapy for the world. In the case of Covaxin, India and South Africa, not just Covaxin, sorry, in the case of COVID, India and South Africa went to the World Trade Organization in October of last year in 2020 and said, please let us get access to these vaccines. We want a waiver, a temporary waiver on vaccine patents, because we anticipate that we're not over with our pandemics in India and South Africa. And of course, that waiver was denied. And on March 5th, 2021 is when the cases started going up in India. That same date was a date that the large pharmaceutical companies sent an open letter to President Biden saying it would be very unfortunate to accept India and South Africa's proposal to waive patents. And as you know, just last week, the Trade Commissioner and the Biden administration did express their support for temporarily waiving patents, but they are not joined by other countries in the EU. For example, Germany, for example, has been opposing this temporary waiving of patents. The other way to get doses to South Asia would be just complete loan or donation. This is an open letter that we wrote, and many people at UCSF and around the world signed, around the country, signed, and we put as an open letter to the Biden administration. There's a similar effort from Duke saying, please take your doses and any surplus doses that we have purchased in the United States, loan them, donate them for global health security to South Asia. Yesterday, President Biden did signal an intent to send 20 million of the mRNA vaccines, as well as 60 million of the AstraZeneca vaccines that the US is not going to use abroad. That would be a total of 80 million doses. And though I commend him and his administration for that, the Duke Research Center has actually estimated that we don't just have 80 million excess doses, we have 300 million excess doses, even if we vaccinate our 12 to 15-year-olds in this country. So we have a lot of surplus doses that we could still donate. And for US to become a global health leader, I think this would be a profound move to give more and more of those doses, given the immediate effect it could have on the pandemic. And I'll end there to get more of the epidemiology from others and then come back for questions. Thank you.
Thank you so much, Dr. Gandhi. That was a very, very comprehensive perspective. And you're also providing some clear recommendations of what could be done if we can reach the 40% threshold with one dose. You claim the epidemic could be halted in a significant way. I do have personally tons of questions for you. I noticed that the audience is submitting already very good questions. Please take a look at the Q&A. But in the meanwhile, I would love to have the reaction of Dr. Yogesh Jain and Dr. Inayat Singh Kakar. you are on the ground. You are in India right now, in different places in the subcontinent. What can you tell us about what is happening? What is your take on why it did happen after months in early 2021, when the epidemic curve seemed to have been going down and down, and many of us were asking, what is happening in India? Why is it doing so well? And then in April, the wall that Dr. Gandhi refers to appeared. Is that something that took you by surprise? Is this something you saw coming? What are your comments on this? I would say, who wants to go first?
So I could, if I may.
Please.
So I think we were taken by surprise as a nation, and the unequal country that we are, we were clearly caught with our pants down, being unprepared for what was going to come in, yet and also ignorant and actively ignoring indications that that things were building up even as late as February 2021, where uptick of number of cases and the rates of transmission rising in certain pockets of the country, as well as the fact that in Europe one had already seen the impact of the variants that had come up in England, if not any other country, and including Brazil also later. So those were not paid heed to by our scientific leadership. As in fact, there was a celebration of the fact that we were probably in the end game for the problem, and the fact that most airborne disease pandemics have second waves, as has happened in the past. How would India be different from anyone else was a question not answered. And I think at another level, there was a pandemic fatigue, which was not only among the people, but also among the system. People were not prepared for something called a chronic crisis. People got tired out. The economy was in shambles, so people wanted to sort of deny the presence of the elephant in the room, as it were. And then we did have this surge, which was built up on opening out in most unscientific ways, and I would say most finally inhuman ways, when the numbers shot through the roof. And over the last 4 weeks, the disease has consumed people who were probably vulnerable in the cities. And as of now, it seems that the peak in the cities has been passed, even though I would say that we are constrained by very poor testing rates in the country. Our test positivity rates in the country are a shameful 18% as of yesterday, which is the rate that US never reached at the peak of its problems, because the testing was kept up pace with the numbers of cases that were being seen. But I would want to add is that the problem has now shifted to the more invisible section of India, that is the rural bits of India, which, even though it is 69% of the country's population which resides there, it has reached in this particular year almost all the villages that I know of. At least I can speak for half the provinces of India. It has reached almost the remotest villages in tribal areas to which I have access to information from those places, and deaths occurring by the dozens, and uncounted and unaccounted for, because testing is very poor, relatively so poor in rural areas that one would die undiagnosed and uncared for, and that's what is the present. I think that will be the defining crisis of 2021, the rural pandemic of India, if I may say.
Yes, and we did see that in other parts of the other regions of the world, like in Latin America as well.
Yeah.
I wonder, Dr. Inayat Singh Kakar, what's your take on all of this?
Right, thank you. So at the outset, I want to clarify, I'm not a doctor. I am a lawyer and a public health professional. Now, coming to my take on this, I would say that, first and foremost, when the pandemic began in India, instead of following a public health approach, taking people into confidence and really focusing on public education around the pandemic, the entire response of the state was, treating it like a law and order problem. So I think that's where the first, issue began. Then, as we saw that the number of cases began to come down, as Dr. Yogesh also said, that the government was dismissing and ignoring scientific advice, and now we know, because there are scientists from the task forces who have spoken up and said that we did want the government. We did speak about how there would be a second surge. We did speak that there would be oxygen shortages, but these were ignored. Also, it coincided with some very important elections that were to take place. And unfortunately, politics, and also I would say religion trumped public health. And therefore, we saw large gatherings. There was a lot of complacency on the part of individuals. And there was a lot of complicity of the media in propagating this narrative that had been created, that the pandemic is over and that India has seen the worst of it. And there was no reporting, there was no, I would say, scientific and evidence-based reporting on what was happening and how pandemics proceed. And like I said, a lack of public knowledge. Also, the lockdowns that were imposed were not taken as an opportunity to actually strengthen our health system. They were not taken as opportunities to strengthen our, services and supplies. And I would say that is where we got, caught off guard, because one, there was no information that that this is coming, and secondly, there was no preparation for any of this.
So let me follow on this, on the political and public health policies in India. It seems that India is under-investing in health. 1% of the gross national product only goes to health. That's probably one of the lowest in the world. And on the political front, it seems that populist leaders, including Mr. Modi, have given preference to saving the economy than saving lives. And also the electoral rallies were probably not responsible in containing. What is it that you can say about the impact of the population, the reaction of the population against the leadership in India?
Dr. Yogesh, do you want to go first?
Okay, so I would say there is a surge on, people, when people see deaths in the family and in the neighborhood and in the community around, it doesn't make, it doesn't allow pleasant feelings to come in. In fact, if those unpleasant feelings and anger and disappointment with the present regime, in the political regime, or even with the scientific community, has been, at least is obvious, is something to be seen, but it also needs to be seen whether it will sustain, in future transactions between the electorate and the political wannabes. But I would say the role of the people, this is a problem with all public health problems. When you are sick, you don't have the possibility to ask for your rights then, because you really want to get over with illness and get treatment. And when you're not sick, you don't bother about your rights in that sense. So I think my fear is that people might forget all this and succumb to the populist leaders, as has happened in all over the world, whether it's Bolsonaro or whether it's your Don that you had till then.
Yes.
Right. I think I completely agree with Dr. Yogesh, that health has never really been anywhere on the political agenda. And our health system has for decades been underfunded. And I think people have gotten used to a public health system which underfunctions and is not optimal. And unfortunately, during the pandemic, the private sector has really taken this opportunity and run with it. And what we're seeing right now is a dominance of the private sector. So right from the time when the pandemic had started, and this is something that we actively worked on, advocating for it, helping patients, and also we're currently in the Supreme Court on this matter. But there was a lot of overcharging and exploitation of patients by the private sector. And it was actually, very late that states actually started setting up treatment rate caps. And because of the kind of clout that the private sector has, there was very little implementation of these rate caps. And I think also the public imagination is and has been very captured by private hospitals, because people perceive that they offer better quality of care, the infrastructure looks better, so people also want, to some extent, I mean, everybody has an aspiration to access private healthcare, and therefore the demand for improving public healthcare has never really been anywhere in the middle of the political agenda. With regards to the anger that people are facing, I mean, I would say, although the media is doing its best to really cover it up and to manage, the image of the pandemic, but of course, when you're seeing deaths and suffering in your immediate family, I mean, through our work, we know of patients who have lost their entire families. I mean, just today, I got to know of somebody who lost, both her parents. Her brother is in ICU, and she lost her husband, and now it's just her and her child. So when people are seeing, so much suffering up close, it is a little difficult for them to ignore that there is political complacency. And there is, a section of the media, then definitely not, the mainstream media, but there is a section of the media that has also been working very hard to bring these things to light, often under fire from, political forces.
Thank you. Thank you for your openness and in commenting this. Monica Gandhi, I do have a couple of questions for you. One, in the last issue of the journal, The Economist, but also in the Institute of Health Metrics and Evaluation of the University of Washington, they claim that the 1 million death mark has already been reached by now. I want you to perhaps comment on the reliability of official data and the projections and estimations by independent sources. But I'm very intrigued by the World Trade Organization TRIPS issue that you correctly marked, and you gave us all the history of HIV and how Brazil and South Africa, India were able to overcome TRIPS in order to be able to produce. And that was a historical landmark. Now, people say that waiving patents now would not allow to fix the problem because of the long time it takes to actually get started in producing these complicated vaccines, that perhaps there are other ways to make it faster. So where do you stand on that? 20 million doses announced by President Biden seemed like a drop in the ocean. The needs in India are far greater, and that's only one country. So what's your take? Should we keep pushing for TRIPS, or should we instead ask for rich countries to donate their surplus?
Yes, I mean, this is a great question, because there is that slide that I showed you. If you look at the Duke Research Center website, they show the majority of vaccines that have been produced. For example, Pfizer has made 1.3 billion doses, and we've passed the 1 billion mark of mRNA vaccines given out worldwide. The majority of vaccines produced have been, I mean, let's use the word hoarded by rich countries. They have. And for example, we have 300 million is likely an underestimate of how many more doses we have in the United States to vaccinate our population and more. And that isn't even taking, because we bought so many doses, and that isn't even taking into account vaccine hesitancy. That's even taking into account adolescents. We still have more than enough vaccine. I think that given what happened in the last administration with global health leadership, this idea that Biden steps up and gives more than 20 million doses and commits, because the amazing thing, why I wanted to show you the inflection point is that if you give vaccine now, and you're right, the TRIPS patent and the waivers to manufacture doses would still take too long. If you give doses now, things plummet, cases plummet. We saw that once you reach a certain point. And so the most immediate thing we can do is fundamentally give doses there. And so we as advocates on this call, I mean, there are 2 letters circulating, not just the letter that I showed you, but there's another from the COVID, it's called the COVID Collaborative. Same thing, same idea, donate doses right now. And I would ask people on this call to advocate for this.
Thank you. I'll give you the word now, Inayat. I just want to alert the audience that my colleague Kemi Amin is monitoring the questions that are coming from the audience. And Kemi, I would ask you to present some of those questions also to do justice to our audience.
Sure.
So why don't we give the word to Inayat, and then Kemi, if you can ask a couple of questions.
Thank you. So I feel that, just a TRIPS waiver, pushing for companies to issue compulsory licenses may not be enough, because what we actually also require is the transfer of technology, know-how, equipment, etc., to enable companies to set up the production quickly enough to be able to respond to what we're seeing right now. And to draw a parallel, the Covaxin that is being produced in India, the company that produces it has given a license to 3 other companies to produce the vaccine, and that's also been accompanied by a transfer in technology. So I would also agree with Dr. Monica that right now, what we need is, of course, donation of doses, and also accompanied with the TRIPS waiver, what we require is, a commitment to also transfer technology, know-how, etc.
Kemi, would you like to pose some questions?
Sure, yeah, we have a question here from an attendee that says, I support sharing vaccines with the world, but how can we ensure that the most vulnerable essential workers and lower income populations will be the ones to get these doses and not the wealthy who are able to shelter for longer? Does India have the government commitment and public health infrastructure to roll out these vaccines more equitably? And then also there was another question from an attendee that's related, which talks about what is the vaccine hesitancy in India? Who are those folks and why are they reluctant?
Maybe Yogesh, you could answer the question about, getting the doses to the right people.
Well, there has been a problem in India also of choosing the right people to get the vaccine. In fact, the strategy started with first vaccinating the health workers, then the first frontline workers, then the people above 60 years of age, then it was reduced to 45 years, and but largely, the recognition was correct. And the demand then was that we should also offer it for those who are vulnerable but are less than 45 years of age. I don't think most of us or any one of us asked for, to be used for anyone above 18 years of age at that time, because we knew that the production was a huge problem, and we made a major blunder in not planning a production in the country. But now when the vaccine comes in, I think one will have to get down onto the drawing board again, and sort of get first available for those people who are at most risk, which would mean the groups that have already been started with in India at that time. Our first priorities were the frontline workers, the elderly, then those with comorbidities, and then those who are vulnerable below 45 years of age. And I think we should do it. In fact, there has been some noise in some of our provinces when people wanted to give the vaccine. Some state leaders wanted to give vaccines only to the extremely poor people in the country. As a positive discrimination, though that was shot down by the High Court of that particular province. In any case, we didn't have enough vaccines to give it to anyone. That was the defining thing. And what was your second question, if I may?
Yeah, sure. So around vaccine reluctancy
yes.
in India.
So I think this is a reality here, and specifically in rural India. When we started with the vaccination program in mid-January, that time in India we had the pandemic on the ebb, and the vaccination was there was a great window to push it. But when this vaccination the process hit the occurrence of the wall, as Monica was put it so well, that time there was a conflation in the minds of people that the vaccine was causing the disease, as well as the deaths that were happening due to the vaccine, due to the COVID, were attributed in the minds of people to the vaccination that was happening, which often which often would be done in crowded settings also. So I think vaccine hesitancy is a real serious crisis in rural India, I would say. So there are these two myths that are going around, that vaccines cause death and vaccines cause COVID directly. And I think methods of mass media, when a demagogue speaks from a television or a radio to tell people that you should use vaccines, is not going to work anymore. We have to get down to the people at their village level, sit with 20 people at a time, and this has to be of a different level of communication with people to get back vaccine hesitancy to be sorted out. Mass media methods are not going to work. This is my impression about handling vaccine hesitancy as I see in rural India at the moment.
Right.
Monica, we talked about vaccine hoarding, vaccine nationalism. And for me, it's obvious that this is not only a case of humanitarianism or of charity. This is also a case of national security. Leaving people unvaccinated in the rest of the world will only lead to more variants being developed. So it's a case of humanitarianism, but also of national security. Hoarding, Canada has more than 13 times the number of doses they need per population. But some people are saying, what about boosters? What about if we need boosters in a few months or in a year down the road? Should we not reserve those surplus of vaccines for boosters? Can you comment on that?
Yes. So this has been used as a reason to keep vaccines here. I actually have an article coming out on Monday about why I don't think we're going to need boosters. And it's a very long explanation of what the vaccines do in terms of generating what's called memory B cell immunity, that B cells are what produce antibodies. And to put it very simply, we know after the vaccines that you can actually take biopsies of people's lymph nodes and see that they've developed after the vaccines, or actually, frankly, after natural infection, memory B cells. Memory B cells last in your germinal center's lymph nodes for a very long time. And in fact, there was a study from Nature in 2008 that they took people from 1918 influenza pandemic. They were 3 to 10 at the time. They looked at them 90 to 100 years later, because they were like 110 by now. And they took people who had survived the 1918 pandemic and saw that their memory B cells could produce strong neutralizing antibodies against the original 1918 strain. So as I always say, I would beware of a CEO of a pharmaceutical company telling us that we're going to need boosters, who has money to make of that, as opposed to the science. And so because of that, I put together a Twitter thread on this, but I've now written an article about why I think it will come out on Monday about why boosters aren't going to be necessary. And I think I actually put that into this open letter to say we don't need to save doses for boosters. We should be sending them because, like you said, it is global health security. We are not safe. No one, this is 101 of infectious disease. No one is safe until everyone is safe.
Thanks, Monica. Inayat, your thoughts, and then Kemi, you can keep on the questions.
Right. I wanted to actually give some background to the vaccine hesitancy that we're seeing in India. So at the time when the trials were being conducted, there were incidents that had come out where the trials were not being conducted properly. So for Covaxin, for example, there was an incident where trials were being conducted on survivors of a mass gas tragedy, people who were already vulnerable. And there were side effects that were being reported, but the hospital that was doing the trial and the company did not acknowledge them. There was a lot of media hue and cry. These were widely reported. But unfortunately, by the end of it, there was no investigation that was done. So I think a complete lack of transparency regarding the data, regarding particularly the safety, is one of the things that contributed to vaccine hesitancy. Second, with regards to Covishield, there was an individual in the southern part of India who had a neurological problem after he took the vaccine. And they were taking the company to court, and the company responded by threatening a defamation lawsuit. So I think it is the response of the companies and the government that has also contributed to the vaccine hesitancy. What was your first question with regards to vaccines? Hello?
Hi, the first question as it regards to vaccines was, let's see, hold on.
Oh, I think it was regarding inequity in distribution, right?
Yeah, it was about the distribution and how can it be distributed equitably, yes.
Right, so I think now there are some states which are gearing up to do more equitable distribution, particularly doing door-to-door vaccinations. But overall, in order to access the vaccine in India, what you need to do is register on an app. That app is only available in English. Obviously, you need to be internet literate to be able to access it. And so, what we're also seeing is that rural areas that border urban towns, people in towns are able to quickly book themselves vaccines, even because if they're not available in your town, people are able to book them in districts which are about 30 to 40 kilometers away because they can drive to them. And so what's happening is that vaccines that are meant for rural populations are being usurped by urban populations who, like somebody said, urban privileged populations who can afford to stay indoors, who can afford, to physically distance. So, but I think there is right now there's a lot of judicial activism going on. The Supreme Court has taken up this issue of, inequitable vaccine policy and implementation. And they are monitoring the situation, and they have asked the center, to put up a proper vaccine plan. So I think now we are gearing up to address the issue of inequity in vaccine rollout.
Kemi, please.
Yes, so can Dr. Gandhi comment on the effectiveness of the 2 vaccines available right now in India? And also, what should be the optimum time between doses? This attendee recently read that 12 weeks was better than 6 weeks for AstraZeneca.
So, the vaccines, the Covishield, which is AstraZeneca, and the Covaxin, which is the part of the pharmaceutical company, are both effective against the vaccine. Against the virus. What percentage? I'd given that earlier in the talk, but they are both 100% protective against severe disease, except that I'll give you a caveat on that. And about 78% or 8 to 80 on mild disease. When I say caveat, someone who is very exposed to a high inoculum of virus, say you've gotten 1 dose of the AstraZeneca and you are exposed in a really big way to a lot of doses. So what would the inoculum of virus, dose of virus, what would that be? A healthcare worker who's only gotten 1 dose of AstraZeneca. there have been reports of healthcare workers getting quite sick. So your severity of disease doesn't just depend on your immunity, but how much, if your immunity hasn't fully developed, but also how much you're getting in. However, in terms of the duration between doses, it's true that the AstraZeneca trial showed us that 12 weeks was better than 9 weeks, was better than 6 weeks in terms of having a duration between doses. It is actually why the UK chose a strategy of vaccinating one and then at 12 weeks. And Canada has adopted that same strategy. However, what Canada did, which I think was wise, is that people who are at risk for a lot of exposure, like healthcare workers, Canada decided to vaccinate their healthcare workers at a shorter time interval so that their immunity was, because of what I just said, all of that exposure would be boosted more quickly. And so what I would advise for India is that that doses are given in shorter succession for people who are working in healthcare settings. And that could be 4 weeks, but that anyone in the general population, it is accurate. It is actually accurate to say that 12 weeks gives you better immunogenicity than 8 weeks, and waiting to 8 or than 9. And waiting to 8 or 12 weeks is fine, even though it feels very anxiety provoking. That is what the data shows. And the reason to wait is to get more of the population vaccinated, which is again, what Canada adopted. And they, even though they've gone much more slowly than we have, because we chose not to give that first dose first and wait on the second dose, they're actually approximating where we are very quickly because we didn't choose to do a 1 dose first strategy.
I have 2 questions for our panelists and whoever wants to answer. First question is about neighboring countries. I'm thinking of Nepal that already has a surge. I'm thinking of Bangladesh with a huge population density, even greater than Bihar or Uttar Pradesh. And then I'm also thinking of Pakistan. So what can be done now to prevent a larger surge in those places? That's question number 1, whoever wants to take it. And the other question is about the indirect consequences of COVID in India. India is the largest producer of other vaccines, children vaccines for the rest of the world. And also, what are the indirect consequences of COVID in maternal and child health and other conditions, health conditions that might be neglected because of the lack of oxygen, because of hospital saturation? Anyone wants to comment on any one of those 2 questions?
I can take question number 2.
Please.
Right. So what we saw, when the lockdown had happened last year, and even right now, I mean, our health system really did not gear up to take in the kind of the numbers of COVID cases that were coming up. And both times what ended up happening is that non-COVID facilities were, directed towards handling the pandemic. And we see a lot of people who, pregnant women in particular have been affected because there are not enough hospitals for them to go deliver at. Patients who require chemotherapy, chemotherapy services were shut down. Patients requiring dialysis are having a really hard time accessing, health services. So I would say that's the impact on non-COVID. Also, could you just repeat the question? I missed a bit of it. So you were asking about the humanitarian cost of COVID?
I'm talking more about the excess mortality, non-COVID, because of people do not have access to hospital beds or health services.
Right. I'm not aware of, that we're particularly tracking non-COVID deaths. And I think there's so much focus on COVID that non-COVID issues are currently not receiving the kind of, importance that they should.
Clearly, in tuberculosis, we have gone far behind, by at least 10 years behind in our rates of coverage, cure rates, and defaults and the relapses that are happening. So I'm sure the same is true for many other diseases, both infectious and non-communicable diseases. In fact, it is the non-communicable diseases care which is suffered the most, because that is usually a long-term thing. It's not, it's important but not urgent in a sense, and those have really suffered. People have dropped out of their diabetes and hypertension and heart disease care, and our mental health problems are not getting the care that they deserve. So those have been really the hidden costs of the COVID pandemic, which might finally become much larger than the COVID cost of the pandemic. Total number, as we know, finally would be 80% among there would be non-COVID deaths. The increase that would happen in the final counting that might be done at some stage. And to your first question about, maybe Monica might answer more about that, but Nepal is doing very badly, far worse than most parts of India at the moment. And also because they have very constrained resources. A lot of oxygen goes only from India, and their patients are dying for the want of any oxygen at the moment. And that's been a really a humanitarian crisis in Nepal. And in fact, most of the aid is coming into India. I've hardly seen of any aid being, sort of being directed towards Nepal, and that's a shame, in fact. And the other is, of course, Bangladesh is doing not so bad. They are doing almost as bad as other Indian states that I would know of, which are in close proximity to Bangladesh. And also Pakistan is doing reasonably better than India, I would say, over compared to, because we messed it up bigger time, and we have certainly, we did many other things which they did not do, which were bad. So I think, so we have done worse than Pakistan, and but that's not surprising to me. Yeah.
Yeah, I would say I did speak to physicians in Nepal last week, and it is a very dire situation because of what you just said. And I've tried to stop saying India and maybe say South Asia more, because it really is not just one country. And Nepal, I put those two together in terms of India and Nepal, because Nepal does not have the access to vaccines that even India has with its 10% rate.
Yes, and also the indirect consequences in terms of economic consequences. In The Economist, it's estimated that 1/2 billion people might become destitute because of the economic impact on families. So I think there's a tremendous sense of urgency, and I hope the world will wake up and provide all of the help the subcontinent and the region needs as fast as possible. Kenny, there are other questions pending from the audience. Would you care to take those?
Sure. I have one question here for Dr. Jain and Ms. Kakar. Can you comment on the best ways we can support access to necessary resources for people who are currently ill now?
So I think there's been sort of a epidemic of offers of help, in fact, in form of oxygen devices, whether it's cylinders, plants, or concentrators from abroad, for people from the diaspora largely, but also from international solidarity. But I would say that we should continue to sort of support these things, but do more so at not engage with states in India rather than engage with the central government. This is to cut the red tape, also to make it more effective, the conversion of these help into sort of outcomes, and as well as it's easier to work with Indian states rather than to work with the large bureaucracy at the central level. I would even argue that for vaccines, if vaccines were given directly to the states, they would do a better job than if one engages with the center. But those might require some hoops to cross through. But I would say it may be worthy trying with Indian states, and also use this the entire pandemic management as an opportunity to shore up the entire systems. As of now, most rural India are clinical deserts. There are no staff, there are no space, there are no systems, and there are no staff. So when you support these with training, with devices, with with money being put into various things, those would be able to shore up the systems for future. For this may not be the only wave or the waves or the walls that may be coming, but also the rest of these things that the health systems have to do. So I would say that would be the best use of the money, not just to squander it away in providing oxygen, which is obviously necessary, but let the government of the day do that job better.
Right. I would say that, definitely work with states, but I would also say that, work on supporting civil society groups that are responding to the pandemic. We have a lot of organizations that are literally setting up, hospital beds overnight. We have organizations setting up oxygen plants in hospitals. And although, I do think that there is still a need, to increase the oxygen capacity of states, because despite the best efforts of even the courts, oxygen still continues to remain in short supply, particularly in tier 2, tier 3 cities, rural areas, because these are places which, from where we often don't hear anything and they get ignored. The second thing I would say is, I think this is an opportunity really for the global health community to reflect, on universal health coverage, I would say. There's a lot of focus on pushing for public-private partnerships, for pushing for privatization in healthcare, and for pushing for insurance-based models. But what we see in India is that the largest, what was touted to be the largest insurance scheme in the world, is really nowhere on the scene. And we see, large-scale economic devastation of families because of the kind of exploitation, economic financial exploitation that is happening at the hands of the private sector. So I would say that we need to reflect, think critically on this, and write more in support of strengthening and improving public health systems. Yes, I think.
We're 6 minutes away from having to close, but I have a policy and diplomacy question for the panelists, whoever wants to take it. One is about whether the US, maybe this is for you, Monica, whether the US should provide the excess vaccines, the surplus vaccines, to COVAX and have COVAX distribute those according to their perceived needs. This is going through multilateral mechanisms, or should the US decide bilaterally to go to India and say, here are the vaccines?
Yes, we addressed that in our open letter, and I did put it in the chat if anyone wants to look at it. We actually suggested a direct donation because a pilot study, for example, in one state in India or in somewhere in Nepal, like something pilot where you give the vaccine and you see those cases coming down, will encourage the rest of the world that this is actually the solution to them not being exposed to virus and global health security. So we suggested a different approach than going through COVAX, where we don't want one more middleman. The idea was as fast as we are actually stressing the need for speed, the need for urgency and expediency.
The other question that I see from the audience is related to how seriously India is willing to invest in health and in public health after this crisis. India is investing hugely in the military. Is there an opportunity, do you think, after this crisis, that some more money will be invested in health in India?
If you allow me to go into this, I would wish really that we do invest more, as I have done before. But the optimist in me says, yes, if there is one time that any leader would see the importance of investing more, it is now. Not only to shore up the system, but also to build up surge capacity for what has been found wanting in most of the management of the pandemic. But the realist in me tells me that political leaders don't understand health issues so well, and the public opinion memory is also reasonably short, and it requires a level of a vision that I think we saw last in maybe in post-war UK, when they made the NHS. I think most of the governments, like even US, spend a huge amount of money in health, or people spend it, and yet people get poor care. So, and there are always a naysayers in India that I hear about, who said that we can't even spend at 1%. Why should we should even decrease it below 1%? Also, there are people who go to that extent. So I'm an optimist, and I hope that people see reasons. People see the reason now. If they don't see it now, then they would never see it. Yeah, to increase the finances.
Well, I'm not particularly optimistic that that India will invest in public healthcare, and I'll give you instances and reasons why. One, despite there being a lot of hue and cry in the media and on social media about the kind of exploitation that people were facing, not just financial, at the hands of at the hands of private hospitals, our government was still pushing for privatizing, district hospitals. That's number one. The second is, we've seen, and me and my colleagues have been monitoring this very closely, the complete lack of will to bring in treatment rate caps and to enforce any of these treatment rate caps. There is a complete, a lack of willpower to do that. And also we have a national law that was enacted in 2010, but that is still not operational due to some technical, issues. And the government has still not, taken that forward and ensured that that law is implemented. The third is that if you look at the, recently the Supreme Court put together a national task force, which was initially set up to look into oxygen, but now their mandate, when the order came out, the mandate was expanded. And out of 12 members, about 9 or 10 members are doctors who are actually, directors and CEOs of large corporate hospitals, not even private hospital, but corporate hospitals. So we see that the entire policy landscape is also dominated by the private sector. And every night, if you turn on any Indian news channel, 9 p.m. is prime time news. You will find all of these private doctors sitting there and, airing their views and talking about what should happen and what shouldn't happen. And unfortunately, they are very close to, state governments and central governments. So I'm not very optimistic that the state will invest in public healthcare. Also, despite, it being 1 year, I don't think we've really seen an increase in investment, in the public health system, whether at the primary level or at the tertiary level.
Well, thank you so very much. We are just at time now. I think this crisis might lead also to reflect on the lessons learned and hopefully make this the last pandemic. We need to prepare ourselves and understand what happened and why, and derive the lessons learned and apply those in a big way globally. I'm very thankful to each and every one of the panelists, Monica, Yogesh, Inayat. You were absolutely fabulous. And I hope we can continue with another chapter revising the situation in India a couple of months from now, see how things are evolving. Just a reminder to the audience that on Thursday, we have a grand rounds with Dilys Walker and a group of panelists looking at the impact on maternal and child health, the indirect consequences of COVID in those two populations around the globe. Thank you so much. This video will be posted in YouTube, and we will be sending the link with Robert Mansfield shortly. Thank you so much, and have a happy Tuesday.
Thank you so much.
Thanks, Jaime.
Thank you.
Thanks, Monica.
Bye now.